going to get right into it. So, welcome, Peter. Appreciate you getting on and doing creating the perfect smile. A lot of good information around this topic, and I think you're the right master technician to deliver the message and education and give the customers the opportunity to see what it takes to create the perfect smile. So,
We'll
welcome,
see about that.
and it's all
Thank you.
yours. All
All right,
right.
thanks. So as always, and Jim and I banter about it. Jim picks a lot of the topics based on feedback from you guys in the audience, and it's kind of it's always fun and it's a challenge. So when I saw this topic come across, I'm like, creating the perfect smile. So that sounds a little challenging. Obviously, there are some aspects about that we can kind of go in and out of for a long period of time, and I'm going to try to harness it as best I can. So first off, let's be clear. Um, what each of us see from an aesthetic point of view is different. Some people's aesthetic version is much different than my aesthetic version. Might be the patients you're working on, or your clinical partners, or the technician's opinion of what they think is right or wrong. And I think merging those things is really part of the challenge to start to understand how we as a team help the human that we're working on, and how we really create for them. Part of the challenge is what you see here. When you look at people on a screen, a lot of times, um, we all think they look great, right? So good looking, they're pretty, everything looks wonderful, and everything is kind of an ideal scenario. And sometimes the teeth are real, sometimes they're fake, and sometimes they've been altered, right? Just for photography and magazines, airbrushed and so forth. So when we look at some of the teeth, if I would show you teeth that look just like this and not a face around it, I think you'd start to say, oh, wow, this could be an ortho case. We could intrude the posterior, or we could do some crown lengthening. And that would definitely make the smile look much better. That would create a more perfect smile. Or the same thing here, right? The centrals have a good length to them, but it's almost a little reverse curve gingivally, right? Where the bicuspids drop down heavily. So on a big smile, you're going to see that. Doesn't sound like a very perfect smile to me. And then when you go to the last one here on the far end of the screen, I mean, they look like pretty teeth, the 8 and 9, but look how the 9 overlaps the 8. Look at the coloration of the 7, and look at the space. Basically, that, between the 10 and the 11, that do you like it or not like it, right? It wouldn't be considered a perfect smile yet. If I put those teeth into the face they come from, you might change your opinion a little bit, right? So if you thought they were great faces to start with, now that you harnessed on just the teeth, now your eye kind of goes right to the flaw in the tooth. But I would argue they are perfect smiles for the faces, right? You can't tell me it's not a good looking face or a good looking face or a beautiful face. Those teeth work in the faces they're in. And I think that's part of the challenge when we talk about what the face is and what the smile really should be for people. So for me, the concept of trying to create this perfect smile and is kind of challenging, because nature has given us something, right? And a perfect example of what nature has given us is if you look at your hand and you see the shapes of your fingers, and nobody would look at a hand and go, oh, that hand's not right. Something's wrong here. Yet, if you change the hand to be more symmetrical and make it look like something different, and in fairness, I want to give credit to Miles Cohen. I stole this picture from him. It's a great photo. Um, the concept of it is look how awkward that looks. It doesn't really fit in the way you think it should fit in. And why is it different with teeth, right? When we look at teeth and we're kind of looking at the face, we're thinking there's supposed to be this perfect symmetry and everything's supposed to line up together. But I would argue it doesn't really work that way. And the more symmetrical we make the teeth, the worse they look in the face. The more square we make them, the less embrasure spaces, the more we're working about keeping everything in straight lines, they really just start to look fake and bad. And I get it, because I'm sure there's a few technicians out there now saying, well, this is what my doctor wants. This is what the patient wants. And I believe that exists. I see that. I would also make the argument, though, that it's not as bad as it used to be, right? Years ago, everybody just wanted straight and white, and they didn't really know anything different. And I have to be honest and tell you that the majority of patients I see, even if they want a whiter, brighter look, they kind of still want it somewhat natural. They tell me, I don't want them to look so fake, but yes, I'd like them a little healthier or brighter looking. And by the way, that's a word I use with them more often is youthful and healthy, right? Because it's not only about white and straight. And I think that's really important to make our patients understand what teeth are. And I know when I do custom shading with my patients, I spend a lot of time going through the details of what a tooth really looks like. So they don't have the vision that you see here on the screen of thinking that that's what teeth are. Because in fairness, they haven't analyzed it the way we have, and it's part of our job to help educate them on that. So in order for the teeth to look proper, it's really about the face you're putting them in. And when you look at all the teeth here, most of them look like they belong in the faces they're in, except for one, right? And that's this guy here, because those teeth do not fit that face. I could say those teeth look good. Even, Shrek's teeth look okay in his face, right? I mean, that works for that particular animal. But when you put something in that looks very fake, it kind of really pops out at you. And that's a big challenge for us today is understanding how to do that. So let me be clear, I'm not going to go into photography today. I've done a million lectures on photography, and I know there's a bunch of webinars on them, and I'm sure I'll revisit them at some point. But you cannot justify creating the perfect smile without taking photographs, without evaluating the face. And the reason I'm evaluating the face is because I want to make sure that I'm looking at all the details of the face and trying to incorporate them into my smile design. So let's get past a few misnomers with smile design. For one, faces are not perfectly symmetrical. They have very similar traits. They have some, let's say, matching family structures. What do I mean by that? The 8 and 9, the centrals, are they exactly the same? Definitely not. They're similar. They're in a similar family. They have similar optics and light reflections. But to say they match each other perfectly is not true. And I'll show you why some of those flaws start to come into play, because we start to think of the face as being perfectly symmetrical from each stage of the face, from the chin up to the forehead, and from the right side to the left side, or the left side to the right side. And I would make that argument that that's not really true. Matter of fact, I was kind of against the digital smile design processes because although I value some of the aspects that we use in teaching digital smile designs, the major component of it is flawed. And what the major component of it to me that was flawed was the interpupillary line. And if you look at the average interpupillary line, over 90% of patients that we work on do not have a perfectly horizontal interpupillary line. So we're using that as a reference point for aesthetics. You're actually skewing the horizontal plane in the face, and that's kind of wrong. I actually did a whole lecture on this years ago at the AACD, I think in San Diego. So I have those slides one day. I should have pulled them out for this actually. But the point of it was, I don't want to use just one reference and think that's the law. I want to kind of be able to look at the face and evaluate. So let's kind of break the face down a little bit so we understand it. For one, facial features to me are really kind of three major components. One, what is the shape of the face? Two, what are the lip dynamics? How do the lips move and what are the shapes of the lips? And then three, the dominant and non-dominant sides of the face. So I know I've touched on some of these over the years, but I want to kind of just quickly run through them so we're all on the same page. So first and most important facial feature for me is the shape of the face. And it's interesting because years ago, I think there were really three types of face, right? There was an oval, more square, or more triangular. And today that's changed. The world has changed. We're in a different environment. There's different nationalities that have really kind of joined together, and it's really changed the shape of our face over the years. So because we were more secluded in our individual tribes, let's say, that's who you mated with, and that's the kind of facial feature that you had. Today, that doesn't really exist anymore. The facial features have changed. So to say there are three types of facial features is really not even close to correct. And I think I have on the screen 1, 2, 3, 4, 5, 6, 7, probably even more than that if we really want to analyze it. There's many different facial shapes that kind of correlate to what we want the teeth to look like. Does that mean that I'm going to match the tooth shape to the face, to the actual shape of the face? No, but it means that I have to think about what that face looks like and not be contradictory with the shape of my tooth. I don't want to put a very square tooth in a very round face and vice versa. So I want to really think through the face shape as I'm working my way through the process. Also, lip dynamics. And this is probably the biggest key for aesthetics today, because I would tell you that patients have what we call an acquired lip dynamic. And what that means is if you're uncomfortable with your smile, I always joke that I had a tooth knocked out at the hockey puck about 20 something years ago now. Today, the tooth was physically in my hand, and it was put back in. I'm kind of a brachial facial face, meaning I don't show a lot of tooth. Now, could I show more? I could, but I think over the years I've kind of arbitrarily conditioned myself not to smile all the way because this tooth is a little bit on the grayer side. If I really want to smile, could you see them? Of course, but I think I'm partially more towards the brachial facial face, but I also think I have an acquired smile. So let me kind of walk you through the three different types of smiles that we normally see. First one is doliofacial, and doliofacial really means that the patient has such a high lip dynamic that you see a lot of pink, also known as vertical maxillary excess. The brachiofacial is kind of what I'm describing in myself. That's where the lip dynamic is a little less mobile, or a little longer, and you see less of the tooth behind it. I always joke that those are the favorite patients for single centrals, because the doctor puts them in and the patient goes, looks great, doc, I'm happy, right? Because they don't really show any tooth, so you don't have to worry about it. And then the mesial facial structure. Now, to be clear, if you break these down into percentages, you're going to find that about 15% of the population is doliofacial, about 15% of the population is brachiofacial, and the rest, 70-ish% is mesiofacial. So the majority of the cases we work on are mesiofacial patients. When you're working on a brachiofacial patient, you shouldn't be altering your plan. You should still be thinking of all the aesthetic parameters, incisal ledge position, height of the gingival architecture, tooth shapes, all the things that come into play should not go out the window. But you do have a little more freedom in the process because they just don't show as much. And it really comes into effect on challenging implant cases where they've lost soft tissue, or the implant placement couldn't be ideal to what we want. Then we're kind of happy to work in that brachial facial. Other side of the coin, the 15% who are doliofacial, the joke that I always say is run for the hills, right? When you're working on them, because those are the challenging cases. There's nothing you can do that is not exposed. And your transition between white and pink is so much more critical to make your tooth structures look proper. And this is really where the ceramic layering and understanding the materials and using fluorescence and margin materials will really come into effect, that I've discussed in so many other lectures. It's really about that junction of the white and pink and how the shape and form fits into the face. But again, the average, 70% of what you work on is pretty much mesiofacial, okay? And then the third part of this would be the facial features. And I explained this so many times, and I think people get it, and it's so easy, but people still tell me, I don't really understand, I don't really see it. So I took an old case that I used to use, and this one's kind of a little bit more of an extreme version to show you. When we look at the face, what am I looking at? I'm looking at the interpupillary line, and I think you can see that his interpupillary line is not horizontal. And I think you can hopefully see, maybe not, but I'll make sure you can see, that one side of his face, in this case, his right side of his face, is much narrower than the left side of his face. And it's actually a pretty extreme difference in this particular patient. Also, I'd make the argument that because he has diastomers and a lot of spacing on the teeth, for a 26 or a 28-year-old, he tends to look very childish. He looks like a 16-year-old or a 15-year-old. Why? Because the teeth look like children's teeth. They don't really fit the face of an adult man. So I want to take this information about the face. I'm going to take his face and divide it in half so you can actually see. If you notice the left side of his face, which is the left side, I'm sorry, the right side of his face, which is the left side of your screen, as compared to the left side of his face, you can see the difference in the width of those two. Now, is this the most important thing for aesthetics? Definitely not. I think he has a good face. His facial features look good. The challenge that I find is when we're building teeth to fit this face. And the reasoning behind that is because when I put the two sides together and duplicate the non-dominant and the dominant side, and you start to really look at what that looks like, it's kind of two completely different people. And when you're building teeth and putting teeth into a face, I think I used to joke that, I don't know if it's politically correct anymore, that this guy was on the wrestling team, he's going to beat the crap out of this guy to make him do his homework for him, right? But it's kind of the way I see it with faces, is that there is a lot of interesting things there. And to be clear, especially men and women, it's these features that really make the face look good. So our job is to make teeth that fit into the face and not just take teeth and put them into a face. It's really to follow those facial features. And in a case like this, and it's an old case, I think I did this about 15 years ago already, but I hope you notice that when we finalize his teeth, he looks like an adult person, a young guy, but compared to what he used to look like, and it's obviously only a few months later, right, when his teeth were spaces and a little longer and uneven, it didn't really fit who he was as a patient. And that was part of our job, to give him the teeth that he's never had, to give him something different. And it's challenging to do that. So that's the face. And now I want to look at the teeth. And now what size should the teeth be? And what shape should the teeth be? And those are all challenging things that we start to put into this now non-symmetrical face that we want to make flow and work with the rest of the teeth. So kind of like the evolution of the face years ago, I think we used to talk about three real tooth shapes, and that was oval, square, and triangular. And those were kind of the only tooth shapes that we really seem to focus on, but not really the case anymore, right? Because you can have teeth that have a squarish edge to them or a squarish basic shape, but yet have rounder incisal corners or softer incisal corners. And I think what we want to do is kind of look at some of the shapes, start to realize that just like the face has evolved, so has tooth shapes evolved. In the end, I still feel like more teeth have a slightly more masculine look to them. And the reason I always say it that way is because men tend to have a more masculine looking tooth. And if you put a very feminized tooth, and what does a feminized tooth mean to you today, right? I mean, as the world is changing, it means to me a rounder tooth and maybe rounder emergence into the gingiva, and that becomes maybe a little more feminized looking tooth. At the same time, when you look at teeth in women, I would argue that a large percentage of those teeth are actually slightly more masculine, meaning that they have a little squarer surface and then rounder edges as they go into the gingiva or around the incisal edges. But they still have a dominant shape that's more in the square or the triangular type of look. And that's why I like to not break the teeth up into only those three categories, right? So we say it's oval or it's square or it's triangular. It really doesn't work well. There really needs to be more detail in that. And the combination of oval, taper, square, round, I think becomes more important where we're complementing the tooth shape to the face. The other challenge with tooth shape is how we place those teeth. And there is a lot of science behind angulations of teeth. Dominant cuspids tend to look a little harsher or a little more dominant when you see that hard angle and sharper point of the cuspid. And you could soften a face or make a more masculine look to a face by how you shape the teeth and how you angle the tooth. So I think it's really important that when I'm looking at teeth, I'm really looking at the long accesses of the teeth and understanding where the root form is, so we follow the proper long axis of teeth. Sorry, I'm stuttering through my words today. It's what happens when you don't sleep enough. So as a great example for me, when I'm trying to recreate a patient's smile, in other words, they've already have teeth that are in somewhat of a good position, we want to improve on their smile either with some minor shape issues or color, well then what I really need to be aware of is the long axis of their tooth. Where is the root that's being formed? And I want to make sure I'm following that root surface. If I'm changing the teeth they have, if I'm giving the teeth they never had, I still want to look at the root form because I'm going to be limited to the tooth shape based on its emergence profile and where it's coming out of that gingival tissue and where the final coronal portion of that tooth actually lies. Now, obviously, in denture world and in some implant cases, we have a lot more freedom in that, but the mindset shouldn't change, right? It's still about putting the tooth in the right position and following the long axis of the teeth, knowing that maybe the centrals have a slight bit of access, maybe the laterals have a little bit more, the cuspids have a little bit more, and you can kind of play with those angles based on the shape of the face. Sometimes a rounder face with severe angles makes it just not fit in very well, right? And a squarer face and making teeth straight up and down also don't complement the face. So we want to kind of look to those details of facial shape, tooth size, shape, and position, and angulation of those teeth to kind of make them work. And obviously, one of the other flaws that I think I see when people are rebuilding smiles is embrasure spaces. Natural teeth tend to have embrasure spaces. And the way I usually describe it is there's a small amount on the centrals, anywhere from zero. 0.2 to almost a full millimeter, depending on the age and shape of the tooth. And that usually increases as I go from the centrals to the central lateral to the lateral cuspid. Now, the smaller it is on the central embrasure, the smaller it tends to be on the lateral, and the smaller it tends to be on the cuspid. But it does always enlarge. It does always get bigger as we go through the process. So being aware of that is important. And the other challenge that I think we face, and this is the one that drives me the most crazy, is, if you're in denture world, we're taking a set of denture teeth. And I get it. The denture teeth are fairly uniform. That's their job when they're making denture teeth. The problem is you're taking a uniform set of denture teeth and putting them into a non-symmetrical face, which is why when you see dentures in people's mouths, in their face in general, you kind of always know they're a denture. And I've joked and I've said so many times that how many times do you see a denture in the face, and as you walk by, you're like, oh, that's a denture. You just know right away because there's something about it that just doesn't flow the right way. So when I'm looking at setting up an all-on case or a denture case, I'm actually looking at the facial features and trying to manipulate some of those teeth. How do I manipulate them? Well, maybe I'm taking away a contact a tiny bit on the left side as compared to the right side, so that I don't have the exact same teeth on both sides of the face, especially if it's an extreme dominant face, meaning that like what I just showed you, right? Where one side was extremely dominant and the other side was extremely non-dominant. If I were to put dentures into that patient's face, it would just look ridiculous. It wouldn't work. So in denture world, I think it's easy to explain that. The challenge is today we're in the digital world. And because we're in the digital world, it becomes more challenging. And that's the reason for that is because just like with a denture setup, in digital space, you're doing the exact same thing. You're taking an ideal mold of teeth from your exocad or 3Shape system, whatever you're using, that's giving you tooth molds. But they're not giving you tooth molds based on the facial feature. They're giving you tooth molds based on a denture setup, in essence. So you really need to kind of rethink that process because, again, when we're just milling out the teeth and not really tweaking and adjusting little contours, you're getting kind of a denture look in the patient's face. That's what we really want to try to avoid. So I think denture all the time, but I also really want to think about the face and how that denture fits into the patient's face. So for me, no matter what the case is, if it's a 2-unit case or a 10, 12, or a full mouth rehab, I'm still thinking denture concept. And the reason I'm thinking that is because the denture concept gives us all the bases for what we need. And what is that? Where does the incisor ledge belong in the face? What does the face look like, dominant, non-dominant size? What is the lip dynamic that I set my gingival architecture to? And then I break it into tooth form, long access, colorations, and aesthetics. I'm kind of really trying to break that through with every case that I do. So if I take a case as simple as this, right, we're only going to do 2 units on this young patient. But again, look at the face. Right away, I hope now that you just saw an extreme version, you can kind of tell that her face is not completely symmetrical. She's a little bit more dominant on her right side, a little less dominant. Face is smaller, not by a lot, a few microns here and there, maybe a millimeter or two, not a lot, but there is something there. And because of that, if you look at her smile, you should notice that it looks like the dominant side of her face, the right side, I see more space. The buccal corridor looks a little larger, whereas in the non-dominant side of her face, it looks like the cheek is closer or the corridor is more narrow. And this is why when you just put teeth in the mouth and you don't think of those things, it doesn't really fit the face very well. So also, just to kind of give you that little guideline, I put 2 lines here to show you. I probably could have put a ruler, but I think you kind of get the gist. And again, is it a foot different? No, it's millimeters, it's microns, but those little differences create nuance, and those nuances create what works and flows in the face, okay? Also, the interpupillary line, it's fairly symmetrical, but not perfectly symmetrical. So if I was following the interpupillary line and I canted her face down, that's going to give me a cant in the plane of her face. We want natural head position for this. And also in her lip dynamic, you can see it's not perfectly straight in the lip dynamic. She tends to pull up a little bit more on the right side, and the lips a little straighter across on the left side. So all those features are what nature has created for us, and our job is to fulfill nature. And in the end, I'm only doing 2 centrals, but yeah, I'm still evaluating all that information to create or recreate her smile for what she's missing. So 2 provisionals, I'm going to fabricate 2 crowns. I think this is an old case. I think I did 1 veneer and 1 zirconia layered crown a lot of years ago. I don't remember the case that well. Very minimal space to work in. But in the end, you can see that what we've tried to do is accomplish it so it flows with her face and that everything kind of works in and blends in shape-wise and color-wise. And I don't know, what kind of teeth would you call those? Are they oval? Are they square-esque with some oval characteristics to them, right? I mean, a lot of it has to be that we can't just have a mindset that these are oval, these are square, and these are triangular, and they fit into this and this face. It's a lot broader today and a lot more complicated when we're doing that. And as we follow up with these patients, we want to see that the gums look healthy and the teeth still blend and that the shapes really fit with what the patient has. And I think that's important to kind of really keep that evaluation going to make sure we understand. And it's interesting because when you look at faces, I showed you, I forgot the patient's name, who that was, the male, with the very dominant and non-dominant sides of the face. But if you look at this face, this is Christy, and you can see right away that Christy has, again, a dominant and non-dominant side of her face. And for those of you who aren't catching it, she's non-dominant on her left and a little more dominant on her right. But really her issue has nothing to do with that. It's kind of like with that first patient, because she has diastemas, she has these long skinny teeth in her face, which is a little more oval of a shaped tooth. It tends to make her look very young. It makes her look like a child, because that's what you would normally see in child teeth, right? The rounder face and the straighter teeth. But she's not. She's 28, and at this point she was getting married and didn't want her teeth to look like that. So we did very minimal treatment on her. We leveled off the incisal edge. I made a few window veneers on her, and again, I think this was probably 6, 7, 8 years ago now. I think she has 2 kids now, right? So the life has changed for her. But in the end, very minimal changes in what we did. We gave her teeth she never had before. So we had to change the aesthetic parameters following the guidelines that we just set into place. And the goal of that was to get a little bit more of a level looking tooth, to kind of fill the spaces and give her more tooth form and angulation, and then make it match her face so she feels more comfortable now when she smiles. And again, 28 years old, we didn't touch her teeth. I guess she's 30 something now. But the point of it is we didn't prep the teeth at all, right? Those were just non-invasive, minimally invasive, or non-invasive, in this case, veneers. So we're following that step over and over again to make sure we could fit it into the face. And the difference between the picture on the left of your screen and the one in the middle is about 4 months later. So it wasn't that big of a change besides for fitting the teeth into her facial features. And it gets more extreme with some faces. This was a young girl. I think when I met her, she was 26 years old, and this poor girl couldn't smile. She had, some real issues with her teeth, and without going too far into it, just quickly. Of course, I did the same evaluations. I looked at the dominant and non-dominant side. I decided where, like a denture setup, where would the teeth belong in her face. And part of understanding the incisal edge position was allowing me then to understand where the gingival would need to be. But again, at 26 years old, we didn't really want to prepare these teeth very much. So we tried to stay as minimally invasive as possible. Diagnostic wax up, which was additive at the time. And we tried that in the patient's mouth as an aesthetic evaluation. For those of you who haven't heard me say it before, I don't use the word mock-up. I'm not a fan of the word mock-up. Mock means to make fun of. And I think I don't know why it became a standard in dentistry, it shouldn't be. What you're really doing with a diagnostic wax up that you're placing into a patient's mouth is you're doing an aesthetic evaluation. You're evaluating what your aesthetic parameters or thoughts were. And I think the aesthetic evaluation phrase gives us a lot more leeway because it doesn't mean we have to be perfect during that evaluation process. It's to determine, did we pick the right incisal edge position, the right shape, the right angulation for those teeth? So it's been a bug of mine for years, but I always push people to lose the term mock-up and stick to aesthetic evaluations when you're really evaluating what you want to do in the patient's face. But interestingly enough, when you look at this particular patient, look at the smile. I want to go back a slide or two because I got to tell you that I remember this case so well. And look at her face. I'm like practically tickling her, trying to get her to smile. Look at the eyes. Look at how she feels about her smile. And this is where that acquired lip dynamic really comes in. And the minute she feels different, it shows in the face. It kind of fits the face. The eyes light up, and you start changing how you feel about your smile, and it gives you a lot more confidence. So we do that with these perfect smiles that we're trying to create, is give the patient a better feel. So this was a Serenity case back in the day, lithium silicate that was milled, and I layered VM11 on it. It was a layered case on the shell of the Serenity material. And it was one of the first ones I ever did, actually. And in the end, she wanted a very white, bright smile. I don't blame her. Years later, we came back and did the lowers. I have some photos on that. But, I still feel heartwarmed, right, when I see her smiling and thinking that, she spent so much of her life feeling so uncomfortable. And no matter how much she tried to feel comfortable, I could see her in the middle, she just couldn't. It just didn't really work for her. And that's really important for us when we're saying we're trying to create the perfect smile, is to incorporate all of those things. So let me just run through, they only have one or two more cases that I'll run through. They're really repetitive though, right? Because in the end, I'm looking for the same things. I'm looking at the interpupillary line. I'm looking at the shape of the face, a much squarer face that I have here. I'm looking for the lip dynamics. How much do they show? How much do they not show? Obviously, I'm working through the functionality and all the other aspects of the case, but this lecture wasn't really about the functionality. It's more about how the teeth fit into the face. And I'll be honest with you, I like sometimes when I see the little angles and rotations, and I think in some faces it actually works better for the face, but I get it. Some people don't want the angulations or rotations. So sometimes you don't have a choice depending on the arch size and the angulation of the arch, but sometimes I think a little rotation actually makes it nice. I mean, look at the smile I showed you on, I forget that famous girl's name now, but when I showed you the 3 or 4 famous people, she had a little overlap on one central and a little diastema behind the lateral, and it works. It looks perfect in her face, right? So sometimes trying to over straighten teeth, I think, is a little bit of a problem too. But anyway, in the short version of this, obviously we functionally consider some orthodontic treatment, which we did. So we were going to open the vertical a little bit by straightening up some of the posterior teeth, straightening up the lower incisal edge position, and tipping out the upper anterior teeth so we didn't have to prepare as much tooth structure. And that was kind of our plan as we worked our way through the process. After we did that, we had to do like we were setting up the denture. Where do the teeth belong in her face? Because the teeth she has isn't the example that we're going by anymore. We want to give her teeth that she hasn't had. So I have to develop the incisal edge position, and I do that like a denture process. Where do the teeth belong in her face? Once I understand where the teeth belong in her face, maybe I want to extend them 1, 2, 3 millimeters, well then I can measure that tooth and say, okay, if that's where I want my incisal edge to be, average central is about 10 millimeters, 10.5 millimeters. Now I know where my gingival needs to be. Will I get the proper length and width proportion just by lengthening the incisal edge? Or do I need to alter the gingival architecture to make that work properly in that patient's face? And that's all part of the smile designing process of where that needs to be. So again, I'll skip through this. And you also notice, though, as I'm getting ready to wax up this case, and I think Jen waxed this case a lot of years ago, you could even see at this point I'm looking at the long axis of the tooth. I'm drawing those lines to show where the root angulation is, because even though I'm lengthening them and I'm going to do some crown lengthening, I want to make sure that I'm following the long axis, not only for the facial aesthetics of the case, but also for the gingival aesthetics. So I know where the zenith goes, or I can communicate where the zenith belongs to the doctor who's doing this surgery. I think this was a Dr. Mike Kuchardi case from years ago. So I'm also going to tip the teeth out a little bit more. And again, I don't want to go into all the little details of this case, because this was really more about the face and the features, but I think you get where I'm going, right? I'm tipping the tooth out, I'm lengthening it, and then we're going to do a little crown lengthening. This is all after the orthodontics to put the teeth in a better position to get us in the right minimally or saving tooth structure mode that we'd like to be in. So start working through the wax up. That wax up will go in the mouth as an aesthetic evaluation. You'll notice that I kind of left a little of the rotations, and the patient did not like it. I don't want any more rotations. I want them straight, no problem. So we're going to come back and kind of redo that. Our evaluation wasn't what it was supposed to be. No problem, right? That's why it's an evaluation. And of course, we discussed it with the patient before, and they seemed open to it until we put the evaluation in the mouth, and they're like, no, I like straighter. So, okay, we'll come back and we'll kind of tweak the wax up a little bit and redesign that aesthetic evaluation. Once we have the provisionals in the mouth, those are not the law for me. Those are just the parameters of where we want the incisal edge and the basic tooth shape and form. I'm going to take a look at that in the picture of the face, and I'm going to make some evaluations. Maybe I want to shorten the 7 and 8 a little bit. I might want to add to the bulk of the cuspid. I might want to get a midline a little bit straighter. It's leaning a little bit to me. So all these little things could be in my aesthetic evaluation wax up, or they could begin to transfer from my clinical partner. It's not a fault of either one of us. It's just what we saw or what we placed at that moment. And all I want to do is take that information and improve on it. So each step we're getting a little bit closer to where that final restoration is going to be. These were going to be feldspathic veneers for the majority of the restoration. I won't bore you with the build-up stuff right now, because I've done so many webinars on build-ups, but I actually did this case as a VM9 case a bunch of years ago, and you guys know most of my techniques already with my canvas and mamelon structures and how I create the translucencies and so forth, but we can always get into that in another webinar. So tooth shape and form, following the long axis of teeth, creating a little surface topography, creating a little embrasure spaces. Like I said, a little on the centrals, more from central to lateral, more from lateral to cuspid. And again, I'm also taking into consideration the age of the patient. And what do I mean by that? If the patient is 20, you'll probably see a lot more embrasure space. If the patient is 80, you might not see as much embrasure space. And I would argue that 20-year-old teeth in an 80-year-old face will never look right, right? Even if we want them to be just a little better and healthier. And vice versa, 80-year-old teeth in 20-year-old face might not look very good either. So you do want to consider the facial, not only the facial features, but the age of our patient. I don't want to sound ageist, but I think there is a little correlation. Again, I don't want to have, just like the two patients I showed you before, right? If I make the teeth too many openings, too many embrasure spaces, too straight up and down, they tend to look very childish, and doesn't really work in a mature face, especially as we get to later 20s and 30s and 40s, it starts to look a little funny. So I kind of try to follow that protocol over and over again, but I wanted them to be youthful. I wanted them to have some natural essence to them, some translucency, some embrasure space, some little kind of imperfection, so they all kind of flow and work together. And that's kind of the way we work with all the faces across the board, trying to make our restorative fit into that patient's face more as an individual than just as a basic form. square, oval, tapered, straight across, all those things. So I'm trying to avoid all those things to make them really fit to the face much better and have the patient feel much more comfortable. So I'll leave you with one more case, and this is a case that I finished up just a few years ago, but it's such a great scenario because this is exactly what I'm talking about. When you're looking at a face, and this is Nina, who's only, I think, 24 years old at this point, and she was born with ugly denture, which really means that she's missing 6 teeth or more, I think is the technical term or definition of that. And this poor young girl had to go through all her life not having teeth. And you know, it's hard enough growing up today, especially with social media and all the challenges that we face with, you know, fitting in and all the things that we do. So it's so emotional to me to think of the challenges that she went through. It's more annoying to think that when she was 18 or 19 years old, she had her implants placed, which I would argue is too young to place implants on, especially for females. The new age is really 24 to 26 years old. So, and I have some cases that I'll be showing you soon, hopefully, where we did place implants at very young ages and it kind of backfired on us. We're actually working through one or two of them now. But in this particular case, the thing that really drives me, and I'll just point it out crazy, is that she went to a dentist. I don't know who it was. And after the implants were placed, they decided that the aesthetic fix in the meantime, while they're waiting for the implant to heal, was to put 2 veneers on her. And I don't really understand that and what the thought was at this point because you're restoring so much. So by the time I inherited the case, the implants were placed, these 2 veneers were done, and there were so many challenges. In the end, though, what I want to kind of to bring this all together is when I look at Nina's face, I'm doing everything like I normally would, right? I'm looking at, let me go back, I'm looking at her face, I'm looking at the interpupillary line, which is not perfectly straight. I'm looking at her dominant and non-dominant side. She's more dominant on her right, less dominant on her left. And I'm trying to think of, you know, even in her big smile, she shows teeth, but she doesn't really show gum. So she'd probably fit into that 70% of the mesial facial patient. So all those things are kind of good for us. Now I want a more youthful tooth. I want some more embrasure space, maybe a little more translucency and some little imperfections. I actually chose an old school metal ceramics for this case. Even though it was a recent case, I still do metal ceramics on certain cases. And the real reasoning behind this was because of all the implants that were placed. Angulations weren't good, and I really wanted to have either a screw channels that I could angle or set screw that I could retrieve. So in the end, I wanted my implants to be retrievable and repairable, and also spacing wise on some of the, because we didn't want to prep more, I didn't have much space for restorative material. So we really tried to keep it as minimally invasive as possible. And then, like I said before, I'm going to kind of accentuate the surface texture and topography, maybe give a little bit more embrasure spaces and a little bit more off angles on the teeth. So in the big picture or in the big smile, and even under fluorescent light, they kind of look good. So in the big picture and the big smile, it all kind of works properly in her face. And that's really our goal, is that when she talks and she laughs and she smiles, everything looks right and feels right for her. I don't know if this video will actually play. Let me see.
Okay. So Nina, how does it feel to be done after all this time?
Amazing. It's I look in the mirror every day and I smile just thinking about how amazing this whole thing has been now that I'm done. But
And you worked with a great doctor, right? So Dr. Castellano was so helpful, I'm sure.
Yes, Dr. Castellano was the best. He treated me as if I was one of his family members, and just the care from everybody and this whole team has been incredible.
How about your comfort level now that I know before we had missing some teeth and there was some deciduous baby teeth there, kind of?
You know, I grew up just kind of smiling with my mouth closed, and I always caught myself in the middle of laughing with a big mouth and just reminding myself, just keep your mouth closed. And now I'm just carefree, and I feel so confident whenever I talk, smile, laugh, eat whenever I'm with anybody, go out to dinner, and I don't have to worry about anything.
Well, they look beautiful and they work great in your face, so thank you.
So, right, that's what the perfect smile is making it fit to the face. I know we'd like to kind of have a more scientific approach and say this is perfect and that's perfect, but it's not. It's really about making the teeth fit to the face. And sometimes I would make the argument that the inadequacies, the differentials, the little details are really what make it work in the face rather than trying to be so symmetrical and so perfect across everything we do. So, Jim, I hope I answered your newest challenge for creating the perfect smile. And I think I'll stop here. Thank you.
Yeah, no, as always, did a great job, and I think it really is that it's very subjective as far as looking at all the aspects. There's not one perfect. What is the perfect smile? There's a lot that goes into it, and so thank you very much. Those of you that are asking your CE, we will give us a couple days. We will process the CE using your registration information. You can also follow up and revisit this video as well as any other webinar that Peter's done on our VITA North America YouTube channel. And then we have a few questions if you have time, Peter.
Sure.
One was, do you recommend a little asymmetry for number 8, number 9 versus perfect symmetry for high aesthetic cases, or should it be symmetrical as possible?
So I don't think 8 and 9 are ever as perfectly symmetrical, but the one thing that should be is the mesial line angles of the 8 and 9. So those line angles coming down the 8 and 9, that's where you want that light reflection and symmetry to really kind of be. Once you go to the distal of the 8 or the distal of the 9, that really has a lot more to do with the actual space that's involved, shape of the tooth, and the face. And you'll notice, a pet peeve, and I'll just throw this out there. When clinicians years ago, they don't do it anymore, but years ago, the clinicians I worked with would tell me, make sure 8 and 9 match perfectly. I always felt like I don't want to work with that clinician because it made me think that they didn't really understand that there is no such thing. The other pet peeve I'll throw in there is match the shade guide exactly. That doesn't exist either, right? So references, but to answer your question, the mesial line angles need to be as symmetrical as possible. And then when you go to the distals, you want them to be brothers and sisters in the same family, but they don't have to be perfectly the same on the distals.
All right, thanks. Another question is, given that if you have room to make things longer, shorter, whatever, is there an average length of tooth form that you want to show, gingiva that you want to show comparable to the smile line, or is it all, again, just very subjective?
So if I'm understanding your question, and let me break it into a few parts. One, the average length is 10 to 10.5 millimeters of a tooth. That means that wherever that incisal edge is, your gingiva should be approximately 10, 10 and a half. Could it be 12? Could it be 9? Of course, right? So there isn't a set law on that. The second part of your question, though, I think was about display, if I'm understanding correctly. And display means how much tooth is actually showing and how much pink is actually showing. And that really has to do with those three aspects I told you, brachial, mesial, facial. That has to do with patient's facial structure and the lip dynamic. The challenge that I think we face the most is patients go online and they read what's an aesthetic smile and they say on the definition of aesthetic smile, you should show 4 millimeters of your incisal, the 8 and 9. And that's really baloney because there's something out there called Botox and Restorative. So every lip dynamic today, I think, is out the window because you're working on patients who have altered the lip dynamic, and it really changes the game. I think some people show teeth, some people don't. You want them to fit in when they talk and they smile and they laugh, not just when they're standing at repose and saying, oh, it should be 3 millimeters longer so I can see some tooth. That rule I don't follow at all.
Okay. Another question, do you recommend using a clear porcelain at the edge of pink porcelain? So I think the question is
Yeah,
more, white and pink and that transition.
yeah. So I think what you're asking, because I mentioned in the lecture, and if I'm answering it wrong, you can re-ask or email me. But I think what I said is when you're in a VME patient and you show pink, the transition between the white and pink is way more critical. It's always critical, but it's obviously way more critical when you can see it. Using translucency really only increases the light optic and lowers the value of the tooth. It's not picking up, it's kind of an old wives' tale that with translucent materials, it picks up the color of something next to it. It doesn't really exist that way. Realistically, you want to kind of do the opposite. You want to use materials like fluorescent materials, things that attract light and reflect light more. So I think the simple answer to your question is I use some translucents on my cervical, but only on top of my fluorescents and opacified materials. And I'm only using it to create a little bit of depth. I'm not using it to pick up the color of the gingiva.
All right. And then another question. You often say a patient is dominant on the left or right side. What are you looking at to determine dominant side?
Width. So the simple answer is width. And I'm looking at I can't see my face straight on, but I could tell you I have one side that's slightly larger than the other. So if I divide it right down the center of my face, and I don't know which it is on me because I'm not looking at a mirror right now, but one side, let's pretend it's my right side, is microns larger from the middle of my face to my ear, where on maybe my left side, if it's my non-dominant side, it's microns or millimeters smaller than that. So it's really just a matter of size. It really that all comes down to.
How on your aesthetic evaluation, how long do you leave it in place, or is it patient specific, treatment specific?
Yeah, so it really depends. I think, look, an aesthetic evaluation is a fancy way of saying mock-up, so let's be clear. And that mock-up that you're doing, which I don't agree with the term, is really more, excuse me, is really more about is it an additive evaluation, meaning that we have not touched the patient's teeth and where we did our wax up over the model and we're putting that in the mouth over the patient's teeth. Could they go home with that? Sure, they can. And sometimes it'll last for 3, 4, or 5 days, and depending on how many teeth you did. The problem is they can't floss. Brushing is harder. You can start to trap, debris underneath the teeth. So I wouldn't let them wear it very long, but they could go home and evaluate it. But when you're prepping teeth and now putting the aesthetic wax up in or the aesthetic evaluation in, that's different because those have now become your provisionals, and those provisionals can go for 3, 6, 8 weeks sometimes. I got cases where our patients are in provisionals way too long, and I'm sure if I look at the screen behind me, Dr. Bernadette's texting me right now, where's that case? Where's that case, right? Because, we can't keep them in provisionals forever either. So that's kind of a challenge and as we work through the process.
All right. And then one last question. When you were talking about abrasure space, were you talking about opening the contact, the facial abrasure space, the length of the contact? What specific open?
Yeah, so it's both, right? So when you talk about embrasure, you're talking about how much opening there is. Let's say we take the incisal edge and how much opening there is as we wrap and the two teeth start to contact. Now, the contact length has a lot to do with embrasure because the longer the contact is, the less embrasure I have. The narrower the contact is, the more embrasure I'll have, but also the type of tooth defines that. A rounder tooth is obviously going to have more embrasure, where a squarer tooth is going to have less embrasure, longer contact area. Just to be clear, contact areas are usually only about 1 millimeter, 2 millimeters long. So usually the pillow fills in about 30 to 40% of the tooth. And then if you have a 2 millimeter contact, let's say just for a number to put it in, we have a 10 millimeter central. The pink papilla fills in almost 40% of the tooth. So at a 10 millimeters, that means I only have 6 millimeters left. I have a contact that's 2 millimeters. That means I've got 60% of the tooth covered. And now how much embrasure do I want that to be? 1 millimeter, 2 millimeters, a half millimeter? And I would really base that on the age of the patient, the aesthetic look that I'm going for, more than anything else. Those are really the two factors, is a more youthful tooth, more embrasure, an older tooth, usually a little straighter.
All right. Well, thanks again, Peter. Any last words for the audience on creating the perfect
No,
smile?
my words are for you. Thanks for the challenge. I think Jim does this on purpose. I think he picks like these topics and I feel like I open up the title and I'm like, oh no, how am I going to talk about that one? And yet somehow at midnight I usually figure something out and kind of put it together. So thank you for the topics. I know you're probably getting them from other people too, but I appreciate it. I will just say that to sum it up, perfect smile is fitting it to the face. That's really what matters. So all the other things are kind of silly. Look at the faces, evaluate it, and evaluate your work in the face, and that's where you can make the tweaks and changes.
All right. Well, I want to thank you again, Peter, taking the time out, doing some education. It's always great. The subject matter is, it's mostly you trying to cover those areas, staying up until midnight and after midnight to try to piece together from your angle what these topics mean. And I
I'm a
appreciate
technician, so last minute, Jim, always.
it.
Technicians are always last minute.
That's right. But they're about realistic real cases, right? And which is great. And I want to thank everybody else for joining us as well. Again, if you want to review this webinar or see some additional webinars that Peter's done, go to the VITA North America YouTube channel. And I want everybody to have a great day, the rest of your day. Peter, thank you very much. You can get back to work, start making some money. All right.
Great to see you. Soon.
All right. Thank you again. Thank you, everyone, for joining us. This concludes today's webinar.